Today, we are going to discuss a classic clinical case of preeclampsia using this step-by-step case presentation. Preeclampsia is one of the most important hypertensive disorders of pregnancy and remains a major cause of maternal and fetal morbidity and mortality worldwide. It is characterized by new-onset hypertension occurring after 20 weeks of gestation, usually accompanied by proteinuria and evidence of end organ dysfunction. Understanding the patient presentation, pathophysiology, clinical findings, investigations, and management is essential because early recognition and timely intervention can prevent progression to eclampsia, stroke, organ failure, placental abruption, and fetal compromise. Let us begin with the patient details. In this case, we have a 26-year-old pregnant woman at 34 weeks of gestation who presents with symptoms suggestive of severe preeclampsia. She is a prima gravida, meaning this is her first pregnancy, which itself is a recognized risk factor for preeclampsia. She has no prior history of chronic hypertension, diabetes, or renal disease. However, there is a significant family history because her mother had severe preeclampsia during pregnancy. This family history suggests a possible genetic predisposition. Up until this pregnancy, she was otherwise healthy and not on any regular medications. These details are important because preeclampsia often develops in previously healthy women during the second half of pregnancy. Now let us look at her presenting complaints. The patient reports a persistent and severe headache that has not responded to routine measures. This symptom is particularly concerning because it may indicate cerebral vasospasm or cerebral edema. She also complains of visual disturbances such as blurred vision, flashing lights, spots before the eyes, or photophobia. Visual symptoms are considered warning signs of severe disease because they reflect central nervous system involvement. She has noticed sudden weight gain and generalized swelling, particularly involving the face and lower limbs. In addition, she reports right upper quadrant abdominal pain, which raises concern for liver involvement and possible stretching of Glisson's capsule. She also experiences shortness of breath, suggesting pulmonary edema, one of the most dangerous complications of severe preeclampsia. Together, these symptoms indicate significant systemic involvement rather than simple gestational hypertension. Moving on to the general examination findings, the patient appears uncomfortable and visibly edematous. There is significant facial puffiness and lower limb edema. Her blood pressure is markedly elevated at approximately 160 over 110 millimeters of mercury, placing her in the severe hypertension category. Hyperreflexia is noted on neurological examination, indicating increased neuromuscular irritability. This finding is important because hyperreflexia often precedes eclamptic seizures. The presence of severe hypertension, along with neurological symptoms, immediately raises concern for severe preeclampsia and the need for urgent evaluation and treatment. The systemic examination further demonstrates the multi-organ nature of this disease. Neurologically, the patient exhibits photophobia and may have positive clonus, indicating significant central nervous system irritability. Respiratory examination reveals dyspnea and pulmonary crackles, suggesting fluid accumulation within the lungs. Hepatic examination demonstrates right upper quadrant tenderness, reflecting liver involvement. Renal manifestations include decreased urine output, indicating reduced kidney perfusion and impaired renal function. The fetal assessment is equally important because placental insufficiency can compromise fetal well-being. In this case, there may be non-reassuring fetal heart rate patterns, reflecting decreased placental blood flow and fetal stress. To understand why these findings occur, we need to examine the pathophysiology of preeclampsia. The disease begins much earlier in pregnancy during placental development. Normally, trophoblastic cells invade the maternal spiral arteries and convert them into low-resistance vessels capable of supplying adequate blood flow to the placenta. In preeclampsia, this remodeling process is incomplete. The spiral arteries remain narrow and high resistance, resulting in reduced placental perfusion. As the placenta becomes relatively ischemic and hypoxic, it releases various antiangiogenic and inflammatory factors into the maternal circulation. These factors cause widespread endothelial dysfunction throughout the body. Endothelial dysfunction is the central event in preeclampsia. Once the maternal endothelium becomes damaged, systemic vasoconstriction develops, leading to hypertension. Increased vascular permeability allows fluid to leak into tissues, producing edema and pulmonary congestion. Platelet activation and microvascular injury contribute to coagulation abnormalities. Organ perfusion becomes compromised, affecting the brain, kidneys, liver, and placenta. In the brain, endothelial dysfunction and vasospasm can lead to headaches, visual disturbances, seizures, and even intracranial hemorrhage. In the kidneys, glomerular injury results in proteinuria and reduced glomerular filtration rate. In the liver, ischemia and swelling produce elevated liver enzymes and right upper quadrant pain. In the placenta, reduced blood flow compromises oxygen and nutrient delivery to the fetus, increasing the risk of fetal growth restriction, distress, and stillbirth. The investigations shown in this case help confirm the diagnosis and assess disease severity. Continuous blood pressure monitoring is essential because blood pressure trends guide treatment decisions. Renal function tests often reveal elevated creatinine and uric acid levels, reflecting impaired renal function. Urinalysis is one of the most important investigations because significant proteinuria supports the diagnosis. Protein may be detected using a urine dipstick, spot protein to creatinine ratio, or 24-hour urine protein measurement. Complete blood count may demonstrate thrombocytopenia, while liver function tests may reveal elevated AST and ALT levels. These findings are particularly important because they may indicate progression toward HELLP syndrome, which stands for hemolysis, elevated liver enzymes, and low platelets. Fetal surveillance is equally critical. Cardiotocography assesses fetal heart rate patterns, while ultrasound evaluates fetal growth, amniotic fluid volume, and placental function. Doppler studies of the umbilical artery may reveal evidence of placental insufficiency. Management of preeclampsia focuses on maternal stabilization, prevention of complications, and determination of the optimal timing of delivery. The first priority is controlling severe hypertension. Medications such as intravenous labetalol, hydralazine, or oral nifedipine are commonly used to reduce blood pressure and decrease the risk of stroke. Fluid management must be cautious because these patients are at risk of both intravascular depletion and pulmonary edema. One of the most important treatments in severe preeclampsia is magnesium sulfate. Magnesium sulfate is the drug of choice for seizure prophylaxis and significantly reduces the risk of progression to eclampsia. While administering magnesium sulfate, careful monitoring of reflexes, respiratory rate, and urine output is required to detect toxicity. Ultimately, the definitive treatment for preeclampsia is delivery of the fetus and placenta. The timing of delivery depends on gestational age, severity of maternal disease, and fetal condition. In severe preeclampsia occurring after 34 weeks of gestation, delivery is often recommended because the risks of continuing pregnancy outweigh the benefits. However, before delivery, maternal stabilization remains the priority. Following childbirth, monitoring must continue because preeclampsia can worsen temporarily during the postpartum period. Blood pressure monitoring, seizure prophylaxis, and assessment of renal and hepatic function remain important. Long-term follow-up is also necessary because women who develop preeclampsia have a higher future risk of hypertension, cardiovascular disease, stroke, and chronic kidney disease. To summarize this clinical case, we have a 26-year-old prima gravida at 34 weeks gestation, presenting with severe headache, visual disturbances, edema, right upper quadrant pain, and severe hypertension. The underlying pathology begins with abnormal placentation, leading to placental ischemia, endothelial dysfunction, widespread vasoconstriction, and multi-organ involvement. Clinical manifestations affect the brain, kidneys, liver, lungs, and fetus. Investigations focus on confirming hypertension, detecting proteinuria, assessing organ damage, and monitoring fetal well-being. Management includes blood pressure control, magnesium sulfate for seizure prevention, careful fluid therapy, and ultimately delivery of the placenta, which remains the definitive treatment. Early recognition and prompt intervention are essential to protect both maternal and fetal health and prevent progression to life-threatening complications such as eclampsia, stroke, HELLP syndrome, and placental abruption.